All right. Well, it looks like we are getting people into the room or the virtual room. Welcome to our, I believe, sixth webinar in this series on advanced HIV. This, I think, is going to be one of our favorites because it's going to be a very open, fluid question and answer session. And let me first turn it over to Bruce Strumminger from ECHO to give us some housekeeping. Bruce?
Great. Thank you, Tom, and welcome everyone. It's our pleasure at Project ECHO to be helping support this really important series of learning sessions on advanced HIV disease in the context of COVID-19. Just a few housekeeping items. First, we do have interpretation in Spanish and in French. So we hope our Francophone and Spanish speakers take advantage of that. If you look down at the bottom toolbar of the Zoom screen, you'll see a little globe and it says interpretation under it. If you click on that, you'll see options for French and Spanish. So please take advantage of the excellent interpretation that's available. Also, there's a chat function in that toolbar. If you're having any IT issues, please chat ECHO IT, and we'll do what we can to try and help you with any Zoom problems you might be having. The main way we want you to share your questions and comments with us is to use the Q&A feature also in the bottom toolbar of the Zoom screen. So we'll be monitoring the Q&A feature, and we really hope you will put your questions and comments there. All the presentation slides and a link to the recording will be shared by email to everyone who registered. So you'll be getting a follow-up email. This session is being recorded and your attendance is consent to be recorded. So thank you for that. Also, there will be continuing professional development credits, CME credits, available through the University of New Mexico, where the ECHO Institute is based. There is a link in the announcement that went out this morning, and we will share a link in the chat about 15 minutes before the end of the session. If you, we really want your feedback. There's a brief 10-question or so survey. It's anonymous, and that's how we do quality improvement and try to improve these sessions. So please complete that, and you will then get an instant electronic CME certificate. So with that, I'm going to hand the mic back to Tom.
Thanks, Bruce. And let me pop my screen up here. And so as I said, welcome. And this is our continuing webinar series on advanced HIV, maintaining care during the COVID-19 response. And this we've culminated into many questions that you guys have been asking us through the question and answer feature on the Zoom webinar over the last 5 sessions. And we also encourage you to use that Q&A feature on this session as well, and we will try to field those questions live. So asking the questions, not answering, but asking the questions today is going to be myself, Tom Chiller, my colleague Alex Jordan here at CDC, and my other colleague Amir Shrufi, who's in South Africa. Just to give some idea about some of the questions that have been frequently asked, we're hearing a lot about how does COVID-19 impact upon risk of death for people with HIV? How do our HIV and TB programs need to adapt? What are the implications for the community response? How do we address stigma associated with now multiple diseases? And many general clinical questions related to advanced disease. So we're going to try our best to hit on some of these today. So let me start by introducing our esteemed colleagues that have been gracious enough to give us their time to be on this panel. We have Dr. Norbert Njeka. He's director of the drug-resistant TB program in the National Department of Health, South Africa, also a specialist family physician with a lot of interest in TB and HIV care. He's chair of the RGLC Afro and member of the Global Fund Technical Review Panel. So thanks for joining us, Norbert. We also have Dr. Gilles van Kutsem. He's the leader of MSF, Médecins Sans Frontières International HIV Working Group, and a senior HIV TB advisor at MSF's Southern African Medical Unit. He's a medical doctor, epidemiologist, researcher, and activist. We also are joined by Solange Baptiste. She is executive director of the International Treatment Preparedness Coalition, or ITPC. She leads community activists and allies across the globe to deliver ITPC's mission to enable people in need to access optimal and affordable HIV treatment through treatment education, demand creation, community-based monitoring, and interventions. She's been doing this for many years and works with many groups, including USAID PEPFAR, as well as many other groups in this space. So we look forward to hearing from Solange today. Thanks for joining us. We also have Dr. David Maya. David's an associate professor in the School of Medicine at the College of Health Sciences, Makerere University in Uganda, and also an adjunct associate professor at the University of Minnesota. He chairs the Advanced HIV-TB Technical Working Group for the MOH in Uganda. He's a clinician scientist involved in a lot of clinical research, but a lot of it's focusing on central nervous system infections and OIs. So David, thanks for joining us. And finally, Mary Ann Davies, Professor Davies is here. She's a public health medicine specialist and pediatric clinical epidemiologist at the University of Cape Town, where she is the director of the Center for Infectious Disease Epidemiology and Research, CIDR, I guess is the abbreviation. She convenes the MPH module on infectious disease epi and joint principal investigator of the IDEA Southern Africa, together with Matthias Egger from the University of Bern, Switzerland. And so we're going to start this Q&A session actually with a brief presentation from Prof. Davies. She has some hot off the data crunching machine information from the Western Cape about some of the risks to HIV patients with COVID. And so Prof. Davies, I'm turning it over to you to share your screen.
Thank you very much. Can you see my screen just before I start?
Yes, we can. Thank you.
Okay, perfect. Thank you very much for the opportunity to share these results on the interaction between HIV, tuberculosis, and COVID. And I'm doing this, although I'm appointed both at the University of Cape Town and in the Western Cape Department of Health. This is really data from the Department of Health that I am sharing today. Now, most of you probably know Cape Town and the Western Cape in South Africa as a place that's nice to go on holiday. And it's probably precisely that because Cape Town is a popular tourist destination, that the Western Cape was the first province in South Africa to see a sharp rise in the number of COVID cases. And for the last few months, we've been known as the epicenter of the outbreak in South Africa. Where are we today? Well, we currently have 62,000 confirmed cases in the Western Cape. I'll highlight that we are no longer testing everybody in Cape Town, only those who are being admitted to hospital or over 55 or with comorbidities. And so we can't really compare our numbers with other provinces anymore. And we have had 1,800 COVID deaths. And in the map of the province, you can see that COVID is really widespread throughout the province, but has been concentrated in the metro. But the Western Cape is not only a nice place, and we don't only have COVID, we also have a very high burden of HIV and tuberculosis. Oh, sorry, this slide was just to show the increase in the deaths in the province that we've seen a doubling. We were having a doubling time of about 8 days. That seems to have dropped off, and that's shown in the blue line in the slide on the left, the graph on the left-hand side. And you can see that the other provinces in South Africa are starting to catch up. And on the right-hand side is a very sobering slide where, or graph, where we're comparing mortality or number of deaths per million for each calendar day, and you can see that we're comparing different countries. So you can see the peaks of many of the European countries on the left-hand side, and their numbers of deaths per million are now declining. And actually, although it's perhaps not fair to consider a province in comparison to a whole country, the Western Cape is probably experiencing the most deaths per million per day, except perhaps for Chile at the moment. And so what is driving this high burden of mortality that we are seeing? And the question that we really wanted to know and was urgent in our minds is what are the effects going to be of HIV and TB on COVID outcomes? We obviously knew about a lot of other risk factors from other settings, but really there wasn't much data from the rest of the world in terms of TB and HIV. Now, over the last several years in the Western Cape, what we have done is to develop a provincial health data center. This isn't an electronic medical record, but what it does is to bring together data on individual patients using a unique identifier from a range of different systems that are used across the public health service. So we bring together data from our emergency centers, all of our hospitals, our primary care clinics, importantly, our disease management systems for HIV and TB, our laboratories, which is important because it includes both private and public sector tests for SARS-CoV-2, and our pharmacies. And from that data, we are able to infer that people have particular comorbidities based on either laboratory tests or treatments that are being given or having coding for particular kinds of encounters. So the things that we're good at inferring are listed on the slide, and those are things that are either associated with particular laboratory tests. In the case of HIV, clearly a viral load or CD4 count or a genotypic resistance test, or with particular kinds of treatment. And again, you can think in the case of diabetes, anti-diabetic medication, or HIV antiretroviral therapy. The things that we're a lot less good at inferring are things that don't get diagnosed in a laboratory or for which we don't give any treatment. So things like being overweight, habits like smoking, individual level socioeconomic status, and cardiovascular disease, because there isn't a good unique drug signature. But with the data that we have, what we were able to do was to put together a virtual cohort of 3.5 million patients who use the public sector and who we could consider to be active in care at the start of the outbreak on the 1st of March 2020, before we had our first case. And these were all people who'd had a visit in the last 3 years. And so we could be reasonably sure that if they had a comorbidity, we would have a pretty good chance of knowing about it from the data we had. And using that virtual cohort, what we did was to look at factors associated with COVID death in the population. We used a very similar approach to the Open Safely study, which many of you may be familiar with, which was conducted in the UK. And essentially, we conducted survival analysis starting at the 1st of March, and the data I'm going to be presenting today was censored on the 9th of June. So we include the whole population, irrespective of whether they actually were tested for COVID, but look at the outcome of COVID death, relying on the fact that most people who would have died during this period, particularly where we were very vigilant around COVID diagnosis, would have received a COVID diagnosis if they had COVID. We did also look at factors associated with death just in the diagnosed cases, all of whom were diagnosed through PCR testing and in our hospital admissions. And because of the PHDC data, we could adjust for the comorbidities we knew about, and we also adjusted for location within the province to account for differences in geographic transmission, and also as a way of adjusting for socioeconomic status, which is very closely linked to where people live. That was for our public sector patients, who account for about 75% of all people in the province, and about 90% of people with HIV and TB use the public sector for their healthcare. But because we do also have people who access private sector, what we also did to look at the whole population was to calculate the standardized mortality ratio, comparing people with and without HIV. And we did that using modeled estimates of the number of people with HIV in the province. So just to have a closer look at those 3.5 million patients, on the left-hand side, you're looking at those who didn't have COVID diagnosed. The middle column is 21,500 COVID cases. You can see that's clearly a lot fewer than we have now. Part of that is because here we're limiting to our public sector active patients, and partly just because we're nearly a month later compared to when this data was censored. And then on the right-hand side, 625 patients who had deceased by the censoring date. If we look at our COVID cases compared to the general population, they're fairly similar, although we do see fewer men. And the reason for that, we think, is because a lot of our initial cases were amongst essential workers in sectors that predominantly employ women, particularly the retail sector. And we do see a slightly higher prevalence of diabetes and hypertension, but not much going on in terms of TB or HIV. If we then look at our deceased patients with COVID, as we expect, they're much older. We see more men, and we see considerably higher prevalence of many of the non-communicable diseases. We do see a slightly higher prevalence of TB, but again, not much going on in terms of HIV. And if we focus in on the patients with HIV who had COVID, what you can see is that in both those who died and didn't die, about 70% were virally suppressed. But we do see a greater proportion in the deceased patients who are either known to be viremic or have a low CD4. So just to take a closer look at people with HIV who died from COVID and compare them to the COVID deaths in people without HIV, the first thing that's striking is the age distribution. And you can see that we have a considerably higher proportion of people under 60 amongst our HIV positive deaths compared to our HIV negative deaths. Now you might think, oh, well, that's just because HIV prevalence is much higher in younger people. And so what I've done in this graph is to compare the prevalence of HIV in our COVID deaths compared to the prevalence in all of our public sector patients. And what you can see is that there's a strikingly higher prevalence of HIV in the COVID deaths across all age groups, but particularly in those under the age of 50, where over a third of our patients dying from COVID had HIV. And it was actually noticing that in our first deaths as they were reported, and in the patients who were younger who were dying, that really made us want to investigate this with urgency. In terms of the other diseases, we see that both people with and without HIV have a high prevalence of non-communicable diseases, but for diabetes and hypertension, this is much higher in people without HIV. And then, as we expect, we see a high proportion of HIV positive deaths having either previous or current tuberculosis. So these are our findings from our survival analysis in the whole population of 3.5 million people. And essentially the graph on the right shows the same thing as the table on the left. And to start off with, as we expect, we see an increased risk in men and an increased risk in people as they get older. Now, these are very big hazard ratios. And so I want to remind you that we are looking at the relative hazard of dying from COVID compared to everybody living in the population. And so just to remind you that the absolute risk of COVID death is incredibly low in our population. So by 100 days into the epidemic, if you're in the youngest age group, the probability of dying is 24 per million. So even though these are very big hazard ratios, they're essentially so many times more than a very low absolute risk of death. In terms of the other comorbidities, we see pretty much what we expect, and in keeping with international studies of an increased risk with diabetes, especially with poor control, and also with hypertension and chronic kidney disease. And then moving on to what's of interest, particularly for this webinar, the HIV and TB, we see around a doubling of risk of death with HIV and current TB, and about a 50% increased risk with previous TB. Although this is adjusted for location, and thus there's some adjustment for socioeconomic status, obviously there may be some residual confounding, partly because of socioeconomic status and also because there are comorbidities that we can't adjust for in our PHDC data, particularly being overweight. That was looking in our public sector patients. If we try to look at the whole population, and that's we looked at the standardized mortality ratio, and what we did was to compare the actual number of COVID deaths in people with HIV with the number that we would have expected if people with HIV had the same risk of death as people without HIV. And the result of that analysis comes to almost exactly the same as what we got from our survival analysis, which is reassuring that we're seeing the same answer from two different approaches with an SMR of around 2.4. And across the public and private sector, we can ascribe about 8% of our COVID deaths as being due to HIV. We then took a closer look at the effect of viremia and immunosuppression on COVID death, and essentially we broke up our patients with HIV into 4 groups. Those who we knew were definitely doing well, who had a recent suppressed viral load and had recently been dispensed ART. Those who were probably doing well, but where their suppressed viral load was a little bit longer ago, or if they'd had recent ART, it was even longer ago, up to more than 2 years ago. Those who we knew were definitely not doing well, who had a recent unsuppressed viral load or low CD4, and those who we really didn't know much about at all. And what you can see is that across all those groups, we do see this increased risk, and the hazard ratios are pretty similar. In the groups that we know the least about, the probably well and the unknown groups, the confidence intervals do cross the null. But in those the groups who have the least contact with the health service. And so although they were assumed to be active patients at the start of the cohort, it's possible that some of them may have moved out of the province. And so that may be attenuating any risks in those groups, and there may be some under-ascertainment of outcomes. The point estimate for the not well group is a little bit higher than the well group, but there were relatively small numbers in those groups, and you can see that the confidence intervals are wide and they really overlap almost completely. On the left-hand side here is the same results that I've shown for our population analysis, and then in the center are the results for when we just look at the cases, and on the right-hand side looking at the hospitalized patients. And this is a busy slide, so I've grouped these in the top in green into age and sex risk factors, the middle are the NCDs, and at the bottom are TB and HIV. And what you can see is that as we move from the population to patients who are increasingly more sick and where there is some selection bias, so cases who had to be symptomatic in order to access testing and had to decide that they were sick enough to warrant going for a test, and then people who required admission to hospital, the effect of all the comorbidities is attenuated. And that makes sense because we've taken out of those groups the people who don't have the comorbidity and are at low risk of poor outcomes. But even in our hospitalized cases, we see about a 50% increased risk of death in people with HIV or previous TB, although the risk for current tuberculosis we can't see once we select just for hospital cases. And then I think in conclusion, what we're seeing is a modest around doubling risk of COVID death associated with both HIV and TB. As I've highlighted, this may be overestimated if there's residual confounding. And it's important to remember that people with HIV are younger and that the absolute risk of COVID death is very low in this group. And so even with a doubling of the risk of death, the risk still remains low. And overall, less than 10% of COVID deaths in our population could be considered attributable to HIV. And just to end by thanking the Department of Health and particularly our frontline health workers and the data center, which was built over many years. And we were just very fortunate to have it ready when COVID arrived. And then, of course, our patients, and to highlight that the data center is partly funded by the Gates Foundation. Thank you.
Thanks very much for that concise and important information. I wanted to start then some of our discussion. Prof. Davies, I think I'm going to ask you just a couple quick questions that I see coming in and that we already had, just so maybe you can help clarify that. And then I'd love to hear from Solange and then maybe Jill on their comments about this data and the situation. But let me start with you, Prof. Davies. There was one quick question that came in live, and it said, "Are COVID?" I think you addressed this, but just to be clear, are COVID HIV positive patients more likely to seek care for COVID and therefore related deaths more likely to be reported?
Yeah, so that's a great question. And I think it's a concern for all the patients with comorbidities, because this is a cohort of people who perhaps are people who are likely to access care. So we did look at the probability of being diagnosed with COVID in the first place. And there was a slight increased risk of being diagnosed, or slight increased chance of being diagnosed with COVID for people with HIV. I think it was about a 20% increase, which was much less so than for some of the other comorbidities. And that may be partly because of their HIV and partly just because those are people that we know about and we know are accessing our health services. But I think what suggests that what we're seeing is not just because of better access to health services and more likely to be diagnosed, is the fact that we see this even when we do restrict to cases and to hospital patients. And that the problem with restricting to cases for sort of our main analysis, even though there is this issue of possibly more diagnosis in people with HIV who are in care, is that you are excluding everyone who's asymptomatic, which might be quite a big proportion of people, and therefore you may not actually be able to see the full effect of any comorbidity.
And then just a follow-up question, why do you think you're seeing this now and you're the first to really report this association? Thoughts on that?
Well, I think there are a number of things. The one is we probably one of the first places with a high burden of HIV that has experienced COVID. What we saw from our data is that certainly if you look just in hospitalized patients, that effect is very attenuated. And so there have been some small studies that have looked in patients in hospital and haven't found an increased risk of death, but their numbers are relatively small. And particularly when you have small numbers, the possibility of seeing an increased risk when it's already a pretty small risk is going to be low. I think the other thing is that we do have a different age profile and a different comorbidity burden to particularly Europe and North America. And so it may be not just the HIV on its own, but the particular profile of our patients with HIV that is driving some of this effect. And then I don't know how important this is, but there was a recent paper published just last week from Spain, which suggested that tenofovir might be protective. Now, most of our patients are on tenofovir because it's our standard first line, but it may be that there's a combination of an effect of HIV or possibly some protection with tenofovir, and so that's making it more difficult to isolate the effect of HIV in itself. But I would like to highlight that, and I take no credit for this, the data center was built up long before I joined the province, but that this is enormously difficult to do unless you have this kind of population level data. And so I think that's also one of the reasons that we're the first people to see this, because we're talking about an outcome that is rare and needing to have good data on comorbidities. And in fact, if we look at our analysis and we don't adjust for age, first of all, we see absolutely nothing going on in terms of HIV. And then the effect increases once we adjust for the comorbidities. So I think having that data has also helped us to be able to sort of tease out a little bit of what's going on.
Great, thanks for that information, and very, very intriguing. And I agree that the data is fantastic to have that kind of data center. I'm going to ask then Solange, you comments on this new data, thoughts about HIV population, et cetera? What goes through your mind? Please share.
Hi, thanks, Tom. First of all, thanks, Marianne, for that very insightful presentation and for even doing this kind of research. It's really important. And I think it helps to answer some of the questions that communities have been asking. I think as one of the non-clinical perspectives on the panel, most of what we try to do at ITPC is try to distill the information so that it will mean something to communities in terms of how to protect themselves and others, right? So what's the purpose of this research is to be able to say, how can we save lives even further? And I think one of the questions we've been plagued with, because there's been a lot of disinformation about how you can get it, how is it spread, and how you can protect yourself, is if I'm living with HIV, am I going to die if I get COVID? And I think one of the questions, I think the study looked at deaths, right? So we were talking about outcomes here, but we didn't look at, in this particular study, whether people living with HIV were more likely to catch COVID anyway. So because I have HIV, will I catch COVID? And I think there's a lot of confusion in terms of symptoms, like COVID symptoms being like TB symptoms, and kind of not quite sure how all these things interplay. So I think this is really insightful, and it's helpful to clarify those two differences in terms of the take-home message. I'm really happy about the size of the study, and I think it's a study that's big enough to find that HIV is a factor specifically associated with COVID death, independent of other comorbidities. But I think we need to think about other structural disadvantages among people living with HIV, and wonder, and it begs the question whether this is very specific to South Africa. So I think this is just the start of what we need to be following. And I just wanted to say thanks and put that out there.
Thanks, Solange.
I was going to just to jump in, maybe you heard from Solange about some of the community and the patient information implications. So would anyone have any comments on programmatic implications of these findings? Do you think it has implications for programs and services that we need to be thinking about?
Yeah, I mean, if I may, thank you, Marianne, for a very interesting presentation. And I'm still puzzled about the probable lack of impact of viral load, and I would like to hear a bit more from you how you interpret that. But I mean, on the programmatic level, well, what strikes me most is that there is an increased risk of COVID amongst younger people as well, who live with HIV, and I think that will change our messaging. That's been very, very much focused on older age groups and people with comorbidities, but people with HIV seem to also die younger. And then I was already worried before about the collateral damage of COVID on HIV and TB services. And I know Norbert is going to say a bit more about the impact on TB, but to me that highlights even more the importance to increase efforts to maintain and actually to regain the losses that HIV and TB services have had due to the COVID and the COVID response. And we know that numbers of HIV tests have gone down, number of TB tests have gone down. And so to me, this highlights the need to revamp our HIV and TB response, go back to pre-COVID levels of HIV testing, initiation on treatment, detection of treatment failure, and catch up with patients who have been lost to follow-up and interrupted treatment in part because of COVID.
Thanks very much, Gilles. Marianne, did you want to come back on Gilles' comment about the viral load? And then perhaps it would be good to hear from Norbert about some of the programmatic implications on the TB program.
Sure. So it is curious, and it's not what we were expecting in terms of viral load. What we think might be going on is that the mechanisms of poor COVID outcomes might be different in people who are suppressed and people who are not suppressed. And what we do know is that even though CD4 numbers can return to normal in people who are suppressed, that there may still be some immune dysfunction remaining. And particularly, and I'm not an immunologist, but I think there's hypotheses around expression of ACE receptors in the lung and around the particular milieu and immune function in the lung, even in people who are suppressed. But also a lot of the people who are suppressed were also people who were older and who had other comorbidities, and that there might be sort of an interactive effect of a combination of HIV and some of the hypotheses around the aging effect of HIV and having comorbidities as well. So we certainly saw a lot of patients with HIV with both diabetes and hypertension in our virally suppressed group. So yeah, it's curious, and we don't know, and it's a whole area to look at and understand, and which perhaps may even offer some insights into treatment of COVID if we get to the bottom of it.
Yeah, thanks, Dr. Davies. I think this might be a good segue. I mean, I think we've heard a bit about the potential implications on COVID and HIV and TB as far as risk factors go. But maybe a question for Dr. Norbert. Can you speak a little bit more about the implications of COVID-19 on TB diagnosis, particularly drug-resistant TB as it pertains to South Africa?
Okay, thank you. Maybe I can quickly share my slides, and then I'll cover that. And then the what we've just said now really worries us, is worrying me as someone working at national level, precisely because the when you look at our data, Western Cape generally has the lowest HIV co-infection, the lowest HIV seroprevalence in the country. In terms of TB mortality, it is also the lowest in the country. So when I see this happening there, it tells me that probably when we start to get the same type of data in the rest of the country, we'll see places where it is even worse. And that becomes a problem. Now, one of the things that we think that should be really done now is to focus on what we did in the past with regard to the fight against drug-resistant tuberculosis. Issues like rapid adoption of new diagnostic. You remember when we introduced GeneXpert in South Africa, it was a big problem, but today we are really moving very fast with, and we already have GeneXpert cartridges for COVID, which is very good. But then parallel process of research and implementation has been very helpful, but quickly decentralizing and effective use of PPEs and making use of partnership, because we do have a lot of universities, and when you listen to Mary-Ann Davis, it just gives you an example of what partnership can really produce between universities and government. But also there are opportunities. For example, we struggled for years to get people who wear masks at facilities because of stigma. And now when I see everyone in the shopping mall, everyone in public having a mask, including the politician, the state president, it tells me that these are some of the things that we need to capitalize on even after these lockdowns are finished. Everybody says contact tracing must be done and all that, and it is happening. Mass screening campaign, mass testing. We try to do those things. So those are things that will help us a lot as a TB program. But the way I see the fight against TB, against COVID, we are at phase 3 right now. We've had phase 1 where we're just preparing ourselves. And then there was a time when we sent everyone to help the services that were providing COVID activities. Now we realize we're in trouble. We're in trouble because there are a lot of issues. For example, DRTB in South Africa, we only have 1,000 patients on our register over the first 6 months. We used to have at least 5,000, 4,500 in the previous years. Now, it tells you that a lot of people have stayed home. They didn't come back after the lockdown. So what to do? We move to phase 3, which is really integrating all these things that our staff have been doing outside back into the TB program. This is just to give you an idea in terms of proportion of TB patients with COVID. This is one of the cohorts. It was one of the parliamentary responses. Parliament wanted to know what proportion of patients were found to have TB and HIV. And as you can see, nationally at that point in time, 19% of patients, and probably this is what we're going to see. I don't know, it's still early data, but more than 10% with tuberculosis. So these are big numbers, and we're very worried about the case finding going down and data incompleteness and all that. So just to finish, really to respond directly, what are we doing? We think that 5 key issues, these 5 high-level steps can be very helpful. We've established coordination structures which are helping us to look at the what you call what is happening. We meet every week, once Tuesday 12 to 2. We had our meeting earlier on to discuss with provincial colleagues and other key stakeholders. And in these meetings, we're looking at our data up to the district level and discuss other issues, drug shortage and all that. We discuss interventions up to facility level, but also we're planning community level interventions, and monitoring and evaluation is key at this point. So this is a really high level of what we are doing to try and respond to a difficult situation. I hope that when all this is in place, patients will come back and our case finding will start improving again, and we will retain patients in care. Thank you.
Excellent. Just interesting stuff from all of you so far, and you know, I'm glad we have another 30 minutes or so to keep this going. We're going to mix it up a little though, and jump to some of the topics. We had some topics and questions about crypto and multi-dosing of meds. David Maya, I know you brought this up on one of the earlier webinars, but let me throw a clinical question at you that we got from a couple folks early on, and that is, you're in a setting where you don't have access to cryptococcal diagnostics. You have a patient comes in with a headache. You don't have access to CD4, so you don't know what their status, immune status is. And the question was, what do you do? Do you empirically treat with something? Do you try to send them to some other clinic that can do a CRAG test or a CD4 count? How would you deal with that situation, and what are your recommendations?
Thanks, Tom. So, challenging question, obviously, given the limitations in resources that we do have in some of the areas in sub-Saharan Africa. But I think cryptococcal meningitis per se should be, you know, the patient who comes in with suspected cryptococcal meningitis per se should be treated just like you would a patient who has suspected meningitis, where you don't really know who is. And so I think depending on, obviously I think having good clinical acumen is important, first of all, to suspect that this is meningitis. And so if that individual is in a setting where they can actually do a lumbar puncture, I think that would be the first thing that I would probably do. Agreeably, if they don't have access to CRAG kits, that's an issue. I think the only thing that prevents is being able to do a cryptococcal antigen test on the CSF that you would have obtained at the time that the lumbar puncture is done. So I think the key things are, one, first of all, getting a lumbar puncture done. In the event that the CSF is under pressure, whether you have a manometer or not, I think you can tell when you stick that needle in that this CSF is under pressure. And so that sort of increases, if it is under pressure, it increases your suspicion of cryptococcal meningitis. If you are unable, so just stepping back, just taking off the CSF and draining your 20 to 30 mils of CSF is, first of all, important for the patient care. You technically started, you would consider that as a therapeutic lumbar puncture already, even at the time that you don't have the CSF CRAG as yet. And if you're in a setting where you can ship off the CSF to another lab in a regional referral hospital, I think that's where you would ideally do it. There are other basic things that you might think through just by macroscopically looking at the CSF. If it does look xanthochromic, then, again, the potential consideration of TB meningitis would be high on your list. But definitely being able to send that CSF off to have a cryptococcal antigen test done somewhere, I think would be useful. You could start fluconazole, 1200 milligrams. In some settings, I think that's what has been recommended if you don't have amphotericin available, and then send off that patient to have cryptococcal treatment done. If you don't have a CD4, but you have a patient in that particular scenario, I don't think that's really critical. I think sending them off to basically determine and get them treated for cryptococcal meningitis, I think would be the first thing that I would do. So that's how I would treat that.
Thanks, David.
Yeah, thanks, David. And I want to just get back to the community side of things just a little bit. I mean, I think this one will be for Solange. After seeing these presentations on COVID-19 and the potential impact on advanced HIV disease care, an aspect of care that's challenging even in the absence of COVID-19, it seems important to be looking increasingly at community-based intervention. So this is sort of a two-pronged question, so I apologize. But the question is, how can linkage to HIV care and retention in care be improved from a community perspective? And are there effective community-based activities that implementing partners or governments should be supporting as a way to prevent people with HIV from developing advanced HIV disease in the first place?
Yes, so that's a pretty big question. So I think, look, if we think about advanced HIV disease, we won't be seeing, or we wouldn't be paying so much attention to it if we dealt with a couple of critical things. And I think one at the root of that is stigma. I think when we start to look at all the clinical treatments and the high mortality rates due to COVID and HIV and TB, if we dealt with stigma, which is probably one of the root causes for people not even entering into the health system and or staying on treatment, if we deal with that, I think we'd be able to get to many of the solutions. We see better health outcomes. Sorry, my thing is making a lot of noise. I'm gonna close that. Yeah, so I think we need to see communities as part of delivering services. So in these teams, so I kind of think of advanced disease, you have the unwell and in the hospital. And the concern there is the unwell in the hospital also being discharged with very in a fragile condition with many confusing instructions and follow-up plans. Then you have those that are unwell but home, and then you have those who are well but are actually not virally suppressed. They feel okay, but they have AHD by clinical definition. So really being able to see that there's a team that includes community members as healthcare providers as part of the clinical treatment plan. So given the current COVID-19 situation, we've seen communities step up with many innovations, being able to not just deliver medicine, but reinforce adherence, check on symptoms. And it is possible for community healthcare workers to be able to go through a checklist and triage and escalate based on symptoms and refer up as needed, rather than requiring a routine clinic visit. So I think we really need to consider teams that include community healthcare workers, so that we expose people less in a hospital setting and help them to get cared at home. I think we need to think more about reigniting home-based care and caring for people at home with their peers. And that could also address some of the stigma issues.
Thanks. I think we had a couple live questions that I thought would be sort of fun to answer. Let's start with Marianne, and then we'll go to Gilles. Marianne, I see there was a question here. It looks like you wanted to answer it. It said, did you look at CD4 counts of those patients that had viral loads? Would the deaths not be associated with those low CD4 despite BLS?
Yeah, so that's a great question. In our national guidelines, if people are virologically suppressed and stable on treatment, we don't do CD4 counts, which I'm sure is the situation in many countries. And so unfortunately, we don't actually, for most of the virologically suppressed patients, we don't have a CD4 measure for several years because many of them have been virologically suppressed for several years. What we did see in the admitted patients, where many of them did have a CD4 count done at the time of diagnosis, is that many of them had quite low CD4s, and that was associated with COVID, with poor COVID outcomes. So particularly patients who at the time of COVID diagnosis had a CD4 less than 200 had an increased risk of death. But we know that COVID causes an acute lymphopenia, and so we don't think those people had low CD4s before their COVID infection, but rather that COVID was causing all their lymphocytes to drop, including their CD4s, and that this is really prognostic of death rather than necessarily causal, and really just a reflection of the fact that they had severe COVID and low lymphocytes. But yeah, it would have been great if we had good CD4 data before COVID, but unfortunately we don't.
Great, thanks for addressing that. And then Gilles, it looks like a live one that you'd like to respond to, which is great. Good question here. Do we see the current efforts aimed at SARS-CoV-2 testing providing an opportunity for HIV and TB screening? Can we integrate the three in one testing strategy? Gilles?
Oh, sorry, I wasn't mute. Yeah, so I think it's a great question, and it's definitely the way to go. That's where we need to go. I just come back from KwaZulu-Natal, where we are doing that, where your COVID screening incorporates a TB screening, and people are automatically referred for TB testing if they have TB symptoms, and actually also includes HIV testing in the screening. I'd also want to have Norbert's input on that, because I think it is already a national strategy in South Africa. But of course, when you look at the decreasing numbers of TB case finding and HIV case finding, something is not working. And but to me, definitely the way to go in the future is to integrate TB, HIV, and COVID screening and testing much more.
Yeah, I agree. It is a policy already. We've asked our think tank TB to to provide a new testing algorithm. We've also taken a decision that, for example, everybody starting their TB treatment should be tested, screened and tested for COVID. And those that will be negative can be tested again if they have new symptoms at some point. So the aim is really to have data on COVID in the same way we've been doing for HIV. So, but I agree with you, numbers are still small. It is still work in progress. Most of our people have not yet returned back to TB services, but the whole thing is going well. They're coming back in big numbers. I hope in months to come, we'll see things start to go back to normal. Thank you.
Great, thank you. Let me go back to David Maya again. David, are you still there? There you are.
Yeah.
So just, we covered again, back to crypto, our favorite disease, which is unfortunately so challenging to manage. We have some efforts underway to get the drug 5FC out and available, which is an oral drug. What are you, are you assuming we can get that drug and make it available? Do you see it playing a role, under the current COVID pandemic because of, again, the challenges of seeking healthcare, getting IV medicines, et cetera?
That's a good question. Well, first of all, the drug, as most of you know, is not yet registered in a couple of countries, especially in sub-Saharan Africa. And so efforts are underway to have cytosine registered through, the UNITAID support, working with CHI and CDC and others. If you go back to the ACTA trial that was looking at different combinations of amphotericin with flucytosine or amphotericin with fluconazole, the oral combination of fluconazole and flucytosine, was sort of the second best performing regimen just in terms of the mortality rates that people who received that combination of treatment had. So I think it was about 35% mortality in that group compared to 24% in patients who received a combination of amphotericin and flucytosine. So I think both ways, that's a drug that could play a role, I think, in, especially in settings where access to IV treatment might be problematic. Whether it would be useful in patients who have cryptococcal antigenemia. So if we sort of go upstream thinking about, cryptococcal antigen screening and preemptive therapy, I think it hasn't really been studied in that particular context, but it's certainly, it would be useful, I think, for patients who have cryptococcal meningitis. If you do combine it, worst case scenario, if you combined it with fluconazole. And perhaps patients could basically take this drug at home if they aren't that sick in the event that they are unable to access hospital settings during this pandemic as well.
Maybe, thanks, David, for that response. So very important to get access to 5FC. Another drug we've had a lot of questions about through this series is liposomal amphotericin B, most people not having access to it. And we've had people ask questions, why is it not recommended if it's safer? Why are we not using it? What's its place in care? Maybe just quickly to get your and maybe Gilles' reflections on, where and how should we be using liposomal amphotericin B?
Yeah. So maybe just to step in quickly, I think one of the key things has really been availability. We know that liposomal amphotericin is a drug that's been used, in Western countries for a long time now to treat cryptococcal meningitis. But there were obviously the cost is, I think, one huge issue, and it's only, I think, in the recent couple of months that the advocacy to have it available in resource-limited settings, I think, have started bearing fruit. There's a current trial that's ongoing now that's looking at the possibility of comparison of using single-dose liposomal amphotericin combined with flucytosine, and comparing that to the standard of care right now, amphotericin and flucytosine for a week. And those results are obviously not yet out. I think there's about 200 more patients to be enrolled. But I think if we do find non-inferiority of those of that combination of single dose amphotericin, I think it will sort of change the whole outlook towards treatment of cryptococcal meningitis. It would probably mean that patients have to stay in hospital for a shorter period of time. It would also obviously be associated with hopefully much less toxicity profiles. And as long as you're able to manage intracranial pressure with therapeutic lumbar punctures in a setting where you don't necessarily need to use manometers would be good. But I think if you're able to treat patients with liposomal amphotericin combined with flucytosine, I think that would ideally be the best regimen to use.
Thanks, David. Let me, so we got about 10 or a little over 10 minutes left, and we'll try to do some rapid round questions. So I'm going to fire some out to you guys and quick answers, and then we'll see how many we can get in here that are being asked. So back to you, Solange. Chase asked about stigma again, and he thought that maybe one point that is overlooked is stigma of healthcare workers toward people living with HIV who stop treatment. And so maybe do you have any thoughts on this stigma and ways to maybe address stigma of healthcare workers on this issue?
Yeah, thanks for that, Chase. Look, stigma is not an easy topic to tackle. I think we've been doing that since the start of this epidemic, and everything else in these unprecedented times is making it worse and more difficult. More data does not change stigma, right? If I give you more data and show you that if you did this and you came in and you would not get sick, will not stop you from being rude. It will not stop you from self-stigma. So more information doesn't change people's perceptions and beliefs. So the approach has to be different when it comes to stigma. And I think that's where we fail. We have a very sort of medicalized approach to addressing stigma. And I think there's much more that can be done. What I've seen, so there have been Lancet studies, I think it was in 2018, that showed that more healthcare providers didn't need more training, but instead they needed more supportive supervision and group problem solving. And I'm not sure how much we're investing in our public health systems to ensure that healthcare workers themselves are supported to be able to know what they need to do and then actually carry it out. Because again, we're dealing with deeply entrenched sort of biases and internalized positions. But what we found to be effective is that you need to go at the local level. Big swaths of global stigma reduction don't work. I think very much at the local level, what's happening in your clinic, what's happening around you within a very small circle, and making those interventions as tailored, as pair delivered, as user-friendly as possible are critical factors in making sure that the healthcare worker and also finding champions, people who people look up to in a particular society or community, small group, that they can say, okay, now I might be able to change the way I think, because some of the stigma is internal stigma and is also experienced stigma. It's also anticipated stigma. Look, ITBC did a 2017-2018 global treatment access survey, expecting lots of treatment issues to pop up. The most pervasive barrier and deadly barrier to HIV still is stigma. So I fully agree that this needs to be addressed.
Great, thanks. You're right. Super challenging issue, and we all need to continue to work on that and think of solutions constantly. I'm curious now about, we've got a lot of questions about sort of medications, and I know you guys are all managing, you clinicians especially are managing sort of medications now in multiple months worth of supplies of these medications, and which has really come to bear in COVID. So I'm throwing this out to anybody to sort of address, but how are you dealing with this concept of giving people multiple months worth of medicines? Is it working? Is it failing? Is compliance worse? Is compliance better? I'd be interested to hear anyone, Marianne, Gilles, Norbert, anybody, to talk a little bit about the challenges with getting multiple months of medicine out.
I mean, can't comment on whether it's working or not, but definitely many sites in many countries have adopted multi-month dispensing, and I think that needs to continue. But UNAIDS has recently called, and we called earlier, for precautions on the impact that will have on potential stockouts further along the line, especially because of the long-term effect of lockdown in China and India, because most of the ARVs are manufactured in India with active pharmaceutical ingredients coming from China, and both those processes, the transport of APIs and the manufacturing of ARVs in India, have had some delays because of the lockdown, and it is likely that there will be a knock-on effect later on. And if on top of that people are going for multi-month dispensing, there's a risk that the countries with the most fragile forecasting capacities will be the ones that will be hit hardest when there is a global supply problem.
Thanks. I think Alex had a follow-up TB Lamb question for you, Gilles.
Yeah, thanks, Joe. I mean, I think we spent a lot of time on previous webinars just sort of discussing the use of TB-LAM, mostly within the hospital setting. I think is one of the potential opportunities of the response to COVID-19. Do you foresee any way to sort of increase the use of tests like TB-LAM or even the CRAG LFA in the community, or at least outside of the hospital setting?
I mean, yeah. I mean, you're well placed to answer this question yourself. But I mean, we Doctors Without Borders, MSF, we've always been advocating for increased use of TB-LAM at the primary healthcare, and I think guidelines, WHO guidelines, have gone in that direction. South African guidelines now also even incorporate the use of TB-LAM at primary healthcare. What is needed is I think increased adoption in national guidelines and implementation of these policies, because TB-LAM remains unavailable in many primary care sites in Africa. I'd say it's the exception rather than the norm to find TB-LAM, and CRAG it's even worse, and that's partially, I think, because of a lack of a lack of incorporation into policy, a lack of a motivation to push for implementation, but we also see some progress on that, a lack of direct funding for these items. But we see that is changing, at least with Global Fund now also funding LAM and CRAG. But yeah, I mean, maybe you want to add on that.
No, I mean, I totally agree. I think that's a good segue into maybe also asking Dr. Norbert. Dr. Norbert, I mean, do you think that there is a role for TB-LAM to play, especially now that conventional TB testing has declined due to COVID-19? Do you think there's a role for TB-LAM to play? With the caveat that it would just be for advanced disease patients, as far as getting those patients getting TB diagnoses back up following the declines.
Yeah, no, I fully agree we started to look more seriously at the LAM test this time around, and just during lockdown, we've revised our guidelines on the LAM. During the weekly Zoom sessions with our provincial counterpart, we learned that there were a lot of challenges which were really preventing the implementation of LAM on the ground, and most of those are being now handled. I hope that very soon we will have a training manual, a different one. So it is definitely very important. Yeah. Thanks.
Yeah,
Thanks.
Tim.
Question, Marianne, for you and maybe others, but you know, I think you presented some interesting data, obviously about HIV risk, et cetera. And you made a comment. You know, you were speculating, I agree, but you made a comment about antiretroviral therapy, at least one of the ARVs used, and whether there might be some benefits. We've gotten several questions, and there's one I see right now. Are there possible benefits from effective and adherent HIV treatment on the outcome of COVID-19? And I know we're still trying to understand that, and there was some early data that was in bad, and ritonavir got thrown in and then back out. So I'm curious, what are you hearing? What are your thoughts on this, you know, adherent and appropriate HIV therapy playing any role with COVID?
I think it's a difficult question to answer, and it's particularly difficult to even try to answer that question with our kind of data, because we have a public health approach to treatment. And so there really isn't enough variation in our regimens in our data to look at this robustly. And also where we do have variation, it's going to be for reasons that would influence your COVID outcome. So for example, in our setting, almost everybody is on TDF unless they have renal failure or unless they've been switched to second line. And of course, both of those things are going to make you at higher risk of poor COVID outcomes. The study from Spain that was published in Annals of Internal Medicine last Friday, and they found that if they looked at the population with HIV, I think the outcome was COVID hospitalization, that people who were on a TDF-based regimen seemed to do better compared to people on other regimens. But importantly, they have really a range of different regimens in their setting, and particularly a big comparison group was people on TAF, which we don't have. So it's kind of hard to know. And they also didn't really adjust for comorbidities as far as I can tell. So again, and they didn't themselves exclude the fact that this might be confounded by comorbidities. But having said all of that, I think the most important thing is that being on effective antiretroviral therapy reduces your risk of a whole lot of other poor outcomes, and particularly reduces your risk of getting TB, and TB increases your risk of mortality itself and increases your risk of mortality from COVID. So certainly being on antiretroviral therapy that is suppressive is undoubtedly beneficial in terms of COVID outcomes, even though we saw an increased risk across ranges of viral suppression. And the other thing, which I didn't include in the presentation, but that increased risk was particularly for people during the intensive phase of treatment. And as we might expect, was particularly for people with rifampicin-resistant TB, although we did see it in people with rifampicin-sensitive TB as well. And so being on suppressive ART that reduces your risk of acquiring TB is clearly going to help in terms of COVID. And you might think, well, that's going to take some time, but COVID is going to be with us for a while. So doing everything one can to avoid the risk of poor COVID outcomes is important.
Great, thanks. And you know, I do agree that it's exceedingly important to get people to be on their HIV medicines for their HIV, and just to not give them any sense of security that being on those HIV medicines means you can take higher risks with COVID. So I think that's really important, right? These are, you need to be on your HIV meds to prevent you from developing more advanced disease and all the complications that come. But that doesn't mean you're safer from COVID. I mean, COVID is still out there. And as we've already seen from your data, it might even be worse in those patients despite viral load suppression. But I don't think we can say for sure that yet, but certainly we can't. I would not want to be giving messages that there's some sort of protective effect yet, just because I want them to take and still be well aware that COVID is out there and you can easily get it. Well, we're at the end, but I wanted to give folks on the panel, if they had any final thoughts or words of wisdom, advice, concern, please take a chance. Solange, just if you had any parting words for us, go ahead.
Yeah, parting words. Look, I think at the end of it all, we need to make sure that we are ensuring clear messaging. At the end of the research, the end of the treatments, as you see patients, people need to understand. And like COVID is so confusing. Like you get a study today and then it changes tomorrow. It was a disease for old people, now it's for young people, now it's for all people. You have to have, comorbidities. It's just very changing landscape. And I think we just need to make sure that the messaging is clear and it connects with people. Don't talk about comorbidities. Talk about sugar. Talk about it in the language that they understand so they can connect with the message and actually take action to protect themselves. Thanks.
Thank you. That's great. Jill, any closing comments?
Yeah, I mean, I think as Marianne said, and Norbert as well, taking ARVs and taking TB treatment has enormous benefits beyond a reduction of the risk of COVID. And I mean, COVID has not only been an epidemic affecting people, but it's also causing a disease of the health system in terms of its ability to continue to provide good quality HIV and TB care. And for me, there have been very good questions asking for increased integration of HIV, TB, and COVID, and also, and I think that really needs to be a focus for the months to come. Is how are we going to resuscitate HIV and TB services from this COVID disease?
Excellent, thank you, David Maya. Final thoughts?
Yeah, no, I think my final thoughts are really around the need to start thinking around the challenges of post-COVID era, and if there's going to be such a thing, there's clearly going to be issues around dealing with the stigma, but there's also going to be issues around dealing with drug availability, and some people on the panel have alluded to potential issues that are going to be in the market around availability and production of liposomal amphotericin and a couple of other drugs that are produced in India and all these other centers that are now producing drugs like remdesivir. So I think that's something we are not thinking deeply about, and especially with advanced HIV disease. I think we need to start mapping out strategies to how we're going to deal with this.
Yes, thanks. Very important concepts and things to think about. Norbert, final words?
Thank you so much. I think for me, what's critical really, HTV programs around the world to consider the oral treatment option. I think in South Africa, if we had not move all our patients to oral, it could have been a disaster by now. I know that TB program like to supervise patients with direct observed therapy. Patient education has been a neglected area, and I think now we need to really educate our patients. A lot of them are also co-infected with HIV. Let's give them oral treatment. They will do better. We should lessen the visits. More visits like before just increase the risk of COVID and other challenges. Thank you.
Thank you. And finally, Marianne, final thoughts?
So I think one of the main messages that we were concerned to convey in doing this research and sharing the results was not to create alarm around people with HIV. And in fact, we might have expected that the risks of COVID death in people with HIV and TB might be much higher. And really what we hope to have done is to have put some quantification around that risk and to show that, in fact, that risk is quite low. And it's certainly a lot lower than for some of the other comorbidities. And so although everybody, whether people have HIV or any other comorbidity, should be doing whatever they can to prevent themselves from being infected and to slow down the spread of COVID, there really isn't a particular reason for people with HIV to be hugely more worried. And in fact, we hope that this data is somewhat reassuring in terms of saying that we've quantified what could have been an enormous risk into something that we now know is not that high.
Excellent. Well, thank you all for such a great discussion. We covered as much as we could. It's hard in these webinars. I think we had great audience participation. This will be recorded, and we will try to address some of the questions we didn't get to today online. So again, thanks everyone. Have a great rest of your day, evening, morning, wherever you may be. And panelists, thanks. Great to see you all. Take care.